exactly do you diagnose COPD?
Okay. Well, let's look here in the pocket guide I have. A clinical diagnosis of COPD should be considered at any time a patient who has dyspnea, chronic cough, or sputum production, and has a history of exposure to risk factors for the disease. So let's review Table 1. In this first table, we're going to consider COPD and perform spirometry if any of these indicators are present in an individual over age 40.
Hmm.
So these indicators are not diagnostic themselves, but the presence of multiple key indicators increases the probability of a diagnosis of COPD. So spirometry is required to diagnose a COPD uh, situation for a patient. Okay.
Mm-hmm.
So let's review this table very quickly. Okay. Spirometry is required to make a clinical diagnosis of COPD. The presence of a post-bronchodilator FEV1 over FVC less than 70% confirms the presence of a persistent airflow limitation
Mm-hmm.
and thus of COPD. So all healthcare workers who care for a COPD patient should have access to spirometry, which we do. All this information can be found in Appendix 1, Spirometry for Diagnosis of Airflow Limitation in COPD, and it summarizes the lung function measurements that are a key in making a spirometry diagnosis and details some of the factors needed to achieve accurate test results.
Okay.
Let me show you this table here on this board behind me. Do you actually remember Mrs. Tubbs' post bronchodilator FEV1?
No, not really. It's a lot of information. It's a little bit overwhelming, so I really don't remember.
Yeah, no, that's totally okay. When I was actually a student at Vol State in their respiratory program, and that's the one out in Gallatin, okay, I actually kind of, had to spend an extra amount of time studying really hard to understand PFTs and spirometry and how they correlate with what we learn about our patients diagnostically. And let me tell you, when I got hired here at Volunteer Medical Center, I actually started working with spirometry and my patients and assessing them this way for COPD, and it really started to click and come together. And it just makes more time. It just makes more sense with time as you practice it, as you get more involved with it. Don't shy away from it just because it's hard. Keep engaging it. You'll find out that it's a lot easier down the road. You'll find out what I mean one day. So I actually want to go back and I'll show you what hers was, okay? So,
Okay. Well, I really appreciate you being so positive and understanding. Actually, my dad had a spirometry test before,
okay.
and I was really wondering how do you use it as a part of assessing if a patient has COPD?
Okay, yeah, we can definitely go over that. Let me explain to you a little bit about what that actually means. And I do want to pull up just a little bit of information about Mrs. Tubbs' spirometry for you to see. So, in our guide, there's a specific part about that assessment that I want to go over with you here. Okay, so first of all, I just want to remind you that spirometry is required to make a clinical diagnosis of COPD. Okay, and it should be available to all healthcare professionals, no matter what, who are working with COPD patients. So, that's part of, why we work so hard to have accurate data and keep our equipment up to date. So it's a simple test, spirometry, that is used to measure the amount of, see right here, it's the amount of air a person can breathe out and the amount of time it takes for them to do so.
Okay, well, how do they measure the exhaled gas?
Okay, so that's determined by using a device called a spirometer, which I have one here in the department for you. So this is a device that's used to measure how effectively and how quickly a person is able to move that air out of their lungs or into their lungs.
Does it show exhaled volume?
It does, and that is actually done with a volume time curve. And we have three here that we're going to review from our previous assessment with Mrs. Tubbs. And there are three main values that we are going to look at and determine from those diagnostics. So the first one is the FVC, that is the forced vital capacity. And it's actually the maximum amount of air that can be exhaled during a breath maneuver. So it's just breathing out really hard and keep blowing, keep blowing, keep blowing. We always encourage our people to keep blowing. Get all of that air out as fast as you can. The second thing that we're going to look at is the FEV1. And it's a little subscript 1. And that is the forced, the forced vital capacity in 1 second. Okay. So the second thing we're going to look at is the FEV1. That's a subscript 1. And that is the forced expired volume in 1 second. So you see here, this is the volume expired in the first second of a maximum exhalation after a maximum inhalation. So this is a measure of how quickly the lungs can be emptied. We know with the FVC, the volume. Now we want to know how fast. And this third portion is a ratio of the two. It's the FEV1 over FVC. And this is going to be expressed as a ratio of the FVC. And it gives us a clinically useful index of airflow limitation. That's the major thing that we want to focus on. In our clinical education, we want to make sure we have that data for that portion specifically. And we do have that for Mrs. Tubbs. Let's see here. We'll go over this in a little bit more detail also.
Okay. Well, it sounds a little bit confusing, and I'm not sure exactly how it relates to gold.
Okay, so with gold, the ratio FEV1 and FVC is supposed to be between 70 and 80% for normal healthy lungs. Anything below 70% is indicative of COPD or airflow limitations. So Mrs. Tubbs right here, her most recent bronchodilator, remember that's the FEV1 over FVC, that's telling us about the airflow limitation, it was only 65% of her predicted. That is less than 70%. That is not good at all. And by using the evidence-based gold categories that they have, this will classify for us the severity of that airflow limitation. So gold kind of gives us the guidelines, the category, the protocols to kind of determine, okay, what does our data tell us? It kind of gives us the direction to go in and tells us a little bit more. This is the assessment tools that we're using. This is what gold comes in for. So, so you saw there it's the 65%. And I do want to go over actually the table of that with you.
So, from what I'm understanding, the gold classification is simply a way to categorize how severe a patient's airflow is being limited based on post-bronchodilator FEV1 values, where GOAT1 would be the most ability to blow out air, and F4 being, and GOAT4 being the worst ability to blow out air?
Yes, that sounds correct. That's actually a very good understanding of that.
Oh, okay. So, does everybody have that same predicted value?
Actually, no. FEV1 is influenced mostly by your age, your sex, your height, your ethnicity even, and it's considered a percentage of the predicted normal value that someone should have. Remember we said that was 70 to 80%. And it's actually, there's actually a vast amount of literature available that, that indicates those appropriate values that we want to use based on local populations for those areas. So there's tons of things that are predictors and indicators for that. So spirometry is needed to make a clinical diagnosis of COPD. Remember that first and foremost. But together with the presence of the symptoms that patients have, spirometry helps us gauge the severity of COPD. It can also be a guide to specific treatment plans that we're going to use in assessing or treating our patient and assessing that progress. So the lower the percentage of predicted FEV1, obviously the worse the subsequent prognosis. If you cannot get air out, you stack it in your lungs, your body's not getting oxygenation like it needs to, you're not ventilating, nothing good happens when those two life functions are gone. So I'm actually, we wrote on the board first table 1, and I want to show you another table really quick if I can. So I want to make sure you understand the diagrams that y-axis was for volume and the x-axis for time, and that's standard. That's what we call a volume time curve, and of course normal versus COPD, you see that drastic difference in where that slope, that line over time, how it drops and comes a little bit flatter, and that volume decreases for what that air they're trying to get out. And the same amount of time as a healthy person decreases. So the FEV1 will decline over time, and it will decline much faster in COPD patients. Spirometry can be used to monitor the disease progression, and it's also reliable, but it's only reliable when the intervals between the measurements are at least 12 months. We want to be able to consistently see a trend for our patients, how they consistently come in and do a spirometry test, okay? So
how do you perform my spirometry?
Oh, I am so glad that you asked, because we actually have one here in the department. I have a bacterial filter and everything. You'll get to try one yourself. I think you'll like it. You'll be just like a real patient. So I actually think that Mrs. Tubbs let's see, it's about 9. She should be done with her breakfast, so we'll have time to do one and demonstrate it with you before we head in and actually assess her.
Oh my goodness, this is gonna hurt.
Actually, no. We'll take some time to do it. I'll coach you through it step by step, and it does require a lot of energy. You have to pull out really hard, but we'll take breaks, and I think you'll really get a better understanding of how it all works. Okay? So we'll go through that, and then we'll get your results. So you'll understand a little bit more about what we drew and what that all means. Okay?